Hello and welcome to our DSM class. Uh, I'd like to begin this course by giving you a little history on diagnosis, and it goes back pretty far. There is a section in our notes on ethics. It is basically uh, a review of ethics that was covered in our theories class. So I'm going to allow you to review that on your own. Um, but let's begin with history of abnormal psychology. And I provided all of these in notes for you to download so that you could use them as a study guide. Um, when you're studying not only for the exam in this class, but for comps and for the NCE, which is the licensure exam. So when we think about all of this, uh, you know, I'm wondering, do you know anybody who may be, I don't know, referred to as an eccentric, other than me, of course, uh, or maybe seen as a little abnormal? Well, what's the difference between normal and abnormal anyway? Or what's the difference between normal and deviant behavior? Might seem a little more extreme with that language. How much is our culture a part of this view? So let me give you some examples. Um, Hearing voices during the grieving process. Uh, that's pretty common in many different cultures. Um, how much of what's considered to be abnormal is related to the time era in which we live? Um, so, what would be considered normal today might not have been considered, quote, normal 100 years ago. Um, What about things like piercing, tattoos, sexual practices? I'm sure you can think of 100 different things. Uh, so, how do we figure this out? What's considered normal or abnormal or deviant? Well, when I think about it, um, there's a little thing to remember, like uh, it's called the 4Ds, and that includes a deviance from cultural norms. Is something causing distress? Uh, is it dysfunctional, or is it dangerous? So consider those 4Ds if we want to think about what is deviant or abnormal. And when I think about it, Um, the main thing is it causing stress or harm to the client or to other people? And of course, that goes along with our uh, limit to confidentiality as well, causing harm to self or others. Let me give you an example. So, uh, years ago, when I was working with um, uh, CYS with children, um, I heard different stories about a child coming in with circles all over their bodies, uh, red circles, and it looked as if they had been tortured. Well, just a couple years ago, and we figured out what it was, but just a couple years ago at the Olympics, when I was watching the Olympics on TV, I saw professional athletes with the same red circles on their skin. Uh, and of course, today we know that That is a traditional practice called cupping, and you take a match or candle and heat the air inside a cup, and it does get rather warm, and then you remove the flame. It sucks out the oxygen and air, and you place that on an area where there is a underlying muscular injury. It uh, creates a suction, and it actually pulls the skin up into the cup. It's so much suction, and that actually increases the blood flow to those muscles and the skin around the muscle. So there is some warrant to that, uh, but many people thought it was a form of abuse. So, uh, yes, is it different? Is it hurting somebody? Well, some might say yes, some might say it's helping people. Um, Same with things like acupuncture, you know. Um, and I can name a lot of different practices from other cultures that in our culture would be considered abnormal. But in other cultures, it's considered perfectly normal. So sometimes, though, something in another culture we could consider harm to others, especially when it involves children, like marriage at a very young age that includes sexuality. We might consider that harmful. So there's a lot of decisions to be made. But, those 4Ds especially, is it harming or dangerous? Is it causing distress to the client or another person? We go back to those very basic ethical choices. Some other things to consider is the behavior biological? Is it organic? Is it emotional? Is it cognitive in origin? Is it a result of nature or nurture? Is the client struggling with some intrapsychic conflict? Is the client able to function independently, or is it impairing their functioning on a daily basis? What's the severity? So one thing you're going to hear a lot from me in this class is the word severity. What's the severity of the criteria? A lot of times people don't consider severity when they make a diagnosis. So if we look at something like ADHD or bipolar and we apply that to a 3-year-old, well, I've got 4 kids, and they can be a little crazy when they're 3, and their moods change at the drop of a hat. So we need to really talk about severity and how it impacts functioning before we make a diagnosis. Just because somebody fits criteria, what's the severity? How is it impacting them? So in many cultures throughout history, abnormal behavior was believed to be the work of evil spirits. 500,000 years ago, religious rituals were often practiced as well as trephination. That's the practice where you take part of the skull and chip it away or drill a hole in it to release evil spirits. Well, think about it this way, though. If somebody had a head injury, like they were hit with a blunt object like a club, well, that might affect their cognitive ability. And it also causes pressure on the brain. So if you actually drilled a hole in the skull, it would actually release that pressure, whether it be blood or fluid, and it would actually change the cognitive functioning of that individual who was suffering from some cognitive damage. So a lot of these things, even though they were based on the wrong reasons, seem to have worked. A different explanation is that it's an early surgical procedure used to release blood clots resulting from fights and blows to the head. 25 years ago, the Greek physician Hippocrates believed that deviant behavior was caused by brain pathology. It's 2,500 years ago, ahead of his time. He also took into consideration heredity, which would be genetics, environmental influences, and he's known as the father of modern medicine. He classified mental disorders into 3 categories. It's really one of the first classification methodologies. Melancholia. I wrote sadness, but melancholy is a little different than sadness. Let's see, it's more like a loss of caring or will. Apathetic sadness. I have to come up with a better definition for that. Mania, euphoria, and featured activity, frenzied activity. Phrenitis, brain fever, or dementia. Early physicians listed hysteria, delusions, hallucinations. But that was really one of the first classification systems. We've got Plato and Galen and continue this research. People were mentally disturbed, should be punished for their actions. I don't believe that, of course. Or they should not be punished for their actions. Sorry about that. Should not be. So they were ahead of their time too, seeing it as a mental disturbance rather than something that needed to be punished. With the fall of the Roman Empire and the rise of Christianity during the Middle Ages, there was a return to supernatural explanations for the mentally ill. And of course, we lost all of that progress and humanity. We went back to cruel measures and punishment. Some instances, the individuals were prayed for and treated with compassion, but in other instances, they were tortured in exorcistic procedures. They were often put in prison, assumed guilty of some wrongdoing, forced to repent. 13th century, many documented cases of mass madness. Many people displayed similar symptoms. It's kind of interesting, tarantism. So think about what that word means. It comes from the word tarantula. So people would dance with hysteria. Think about what the men and women would wear. So many layers of clothing, so many buttons and laces, and they could not dress or undress very easily. So if a bug got in their clothing, they were pretty fearful. The dancing usually took place at the height of summer, attributed that time to the bite of a tarantula. Of course, it was just mass hysteria. Later became known as Saint Vitus's dance. Another early disorder, lycanthropy. Of course, lichens. There's a movie about that. People imagine themselves to be wolves. It's where our current idea of werewolves comes from. An early mass delusion. And then 15th, 17th centuries, a long period of time there really, mentally ill were often thought to be witches. 1486, they wrote Malleus Maleficarum, or Maleficarum, or the witch's hammer. Monty Python made a whole movie about this. And it talked about how to identify witches by means of birthmarks or clubbed feet. And of course, we know this is just superstition. Finally, we had the rise of humanism, began with the Renaissance. 1563, John Weyer, German physician, published a book that challenged the foundation of witchcraft. And of course, it was banned by the church and state. However, The movement had begun, which viewed mentally ill individuals as people who were sick rather than possessed. Of course, uh, Hippocrates, uh, Plato, they knew this, and it was lost uh, through superstition and religion. Asylums grew in number between the years 1400 and 1700, the most famous of which was London's Bethlehem Hospital. So think about an English accent from that area, London, Bethlehem, Liverpool, and how would an Englishman pronounce Bethlehem? Well, they might pronounce it Bethlem, Bethlehem, Bethlehem. So you can see where the word Bedlam, Bethlehem, came from. And if you were to walk into that hospital, people were running around, people were chained, people were getting all kinds of crazy treatments. And it was chaos or bedlam. So people were really saying, oh, if children were acting wild, it would say, it's Bethlehem Hospital, it's Bedlam. And that's where that phrase came from. So during the Reform movement, 18th, 19th centuries, Philip Pinel, physician in France, was put in charge of Le Bicêtre Hospital for the insane men of Paris. They're still a little crazy there. He had been influenced by Jean-Baptiste Poussin and began the moral treatment movement, a shift to more humane treatment of patients. Had inmates' chains removed, replaced dungeons with sunny rooms, encouraged exercise outdoors. In England, a Quaker tea merchant named William Tooke formed a retreat in York for the moral treatment of mental patients. United States, Benjamin Rush fathered the movement for humane treatment of patients and began the concept of work therapy, where patients held jobs in the hospital grounds, became known as the father of psychiatry. And they also used horticultural therapy, which I think is pretty good. So we have a little ways to go here, but even though this seems like a lot of information, I really pared it down to just an outline of the facts that you need to know. So I know it's a lot, but I took an awful lot of information and put it in a very condensed format for you. So we look at New England school teacher named Dorothea Dix. You really need to know that name. That's why I'm bringing that up. Great American social reformer in the 19th century. While teaching Sunday school to mental patients, that were still held in prison, she campaigned for better treatment and living conditions. Even though there were great strides in treatment, such as bloodletting, purgatives, and astrology were still used, which of course were not great treatments. They caused more harm than help. 1908, Clifford Beers published A Mind That Found Itself. Talked about his own mental collapse and terrible treatment. Beers founded the National Committee for Mental Hygiene, later the National Mental Health Association. Mary Jane Wards wrote a book called The Snake Pit in 1946, right after World War II. Frederick Wiseman's Titicut Follies in 1967. So, and more recently is the article that I gave you to read this week, Being Sane in Insane Places. I'll be interested to hear your reaction on that in your discussion posts. And then, of course, they began biological viewpoints, of course, hypocrisy, largely ignored later in society until the 19th century, until the 1800s. German psychiatrist named Wilhelm Greisinger believed that all mental disorders had some physiological cause. Emil Kraepelin followed Reisinger, observed that certain symptoms appeared in clusters or syndromes, uh, believed that each syndrome represented a disorder and a unique organic cause. So now we know that there is both emotional trauma and physical causes for various things. It's a combination of both. He outlined 4 organic causes: metabolic disturbance, endocrine difficulty, brain disease, or heredity. Outlined a basic system for the classification in 1883, the textbook of psychiatry, originally the basis of the DSM categorization. So we skipped hundreds of years in there. We're finally back. Psychological viewpoints. One of the earliest challenges to the organic was from an Austrian physician named Friedrich Anton Mesmer. Think about his name, to mesmerize. Yeah, so he practiced in Paris during the 18th century. Didn't become mainstream as treatment was known as mesmerism. Became the forerunner of modern hypnosis. So mesmerism was used to treat psychosomatic symptoms related to hysteria. And U.S. Ambassador in France, Benjamin Franklin, later declared him a fraud and left Paris. James Braid later renamed mesmerism neurohypnotism, which is where we get the word hypnotism. Jean-Martin Charcot and 2 physicians who worked together in the eastern French city of Nancy, Ambrose Auguste Theobald and Hippolyte Marie Bernheim, hypothesized that hysteria was actually a form of self-hypnosis. I know I'm running through a lot of names. We're almost done with the names. And Joseph Breuer, of course, found that after his patients spoke freely regarding her past traumatic experiences, her symptoms disappeared. This became known as the cathartic method. And of course, Freud studied under Breuer. So, medication viewpoints. Since the discovery of psychotropic drugs in the 1950s, been a trend of deinstitutionalization. This is a problem. So from about 600,000 patients in the mid-50s to about 80,000 a day, yet the number of cases has risen from 1.7 million in the 50s to 22 million today. So, that's a lot. So, but they're all outpatient. And why is that? The drug industry influencing diagnoses. All right, so let's talk about the DSM specifically. Very first classification of mental disorders in the United States was for statistical purposes in 1840 census. Only one category, idiocy or insanity. Very primitive. 1880 census, 7 categories: mania, melancholia, monomania, paresis, dementia, dipsomania, and epilepsy. 1917, Committee on Statistics of the American Medico-Psychological Association, now the American Psychiatric Association, and the National Commission on Mental Hygiene created a plan for gathering statistics in mental hospitals. The APA later worked with the New York Academy of Medicine to develop a psychiatric nomenclature, which was included in the first edition of the American Medical Association Standard Classified Nomenclature of Disease. After World War II, the World Health Organization published the 6th revision of the ICD, so the International Classification of Diseases, which included a section for mental disorders. So there we have, like right after World War II, 1940, 46, 47. The ICD was primarily for physical diseases. But then the DSM came about in 1952. And so then we have both the ICD, I think now we're on 10, maybe? Correct me if I'm wrong, if anybody knows. And we also have the DSM-5. But most people look at the DSM revisions by the color of the book. And I would love to get some of these older ones. They're very expensive. DSM-1 is the brown book. DSM-2 is the gold book. DSM-3 is the green book. So I actually started with the green book, believe it or not. I don't have a copy of it anymore. I have a blue, 3R. R stands for revision. They changed that to TR, text revision. Maroon, silver, and now we're on purple. It's based on the medical model, and there are pros and cons to it. It helps us to organize a means of analyzing potential disorders. Clients maintain a higher faith in the therapist as like a medical doctor. And it provides a means of tracking disorders with medication, treatments, and origins, and insurance, and all that stuff. Negatives, diagnoses label people, and misdiagnoses. It is very difficult to get a misdiagnosis out of your system files, like medical records. The concept of a cure, often there is not a cure. Client and therapist are not seen as equals in the medical model, and there's a lot of negatives. But having that diagnosis on a medical record with all of the electronic systems now, it could be very detrimental. So if you think about it, if somebody was misdiagnosed with schizophrenia and all of the symptoms went away, they would be diagnosed then with schizophrenia in remission. So it never actually goes away once you get that diagnosis. Think about the pros and the cons, and maybe you'll come up with some that I did not mention. I know that's a lot of information, but you can also use this as a study guide. A lot of these names will appear on some of those larger exams. And also think about some examples of what's considered, quote, normal or abnormal, and what goes into that consideration. How much does diversity in culture and differences between culture play a role in those decisions? All right, I'll be interested to read some of your comments. Thanks.